So I think we are live on onto YouTube, and Arti madam, we can start.
Right. Can you allow me to share my screen, Jay?
Yeah, 1 minute.
Yeah, before that, can I announce that Project Pelvis is now 22,000? I would like Aarti to make a comment on.
Yes, yes.
We have enabled you to share screen, madam.
Right, right.
Oh, so before Aarti, can you just make that announcement and then start your slide, please?
Right, right. So, first of all, welcome everyone to the BLAST series on adenomyosis. And Jay, we are very proud of you and all the team members at Project Pelvis that you have reached 22,000 plus subscribers for this Facebook channel, which you have started years ago. Many congratulations on this, Jay. We're also proud of you.
Thank you, madam. Thank you. Thank you. All your blessings.
I think we have blessings of our colleagues, our seniors, teachers, elders, and that's the reason why we've come so far.
Correct.
Yes, and the last 4 BLAST series have been very enriching in terms of the content and knowledge which was shared. And if you look at how far we've come, Jay, in the BLAST series, we discussed about pain management. We discussed in the second episode on non-surgical interventions for a patient with adenomyosis who has completed her family. All the options were discussed. The third series, we discussed about pre-IVF management of adenomyosis. So really, we've discussed quite a bit. And again, I congratulate you on this 22,000 plus mark, which you have reached. And we'll jump right into the session. I've got many queries from many of our colleagues on groups and personally, Jay. And they wanted us to touch a bit about imaging in adenomyosis. So can you please give your comments on whether ultrasound is enough and what are the features?
So I think I will use a simple statement here. When the ultrasound is done by a good person, what I mean to say by a good person is somebody who has experience in ultrasound and on a good machine. Now, I really don't want to categorize anything as a bad machine. But see, most of the ultrasounds which we have seen are on either Volution E8 or E10. If you look at the images, no, everything is E8, E10. These machines are as expensive as an E-class Mercedes. Okay, they are approximately 75-80 lakh rupee machines. So definitely there is some difference in the gain optimization of these machines. You can't really deny that. Okay. I personally think as long as you are able to do a systematic evaluation, this systematic evaluation includes evaluation of adenomyosis with endometriosis, along with involvement of the kidneys, because that is something which commonly gets compromised. Okay, then your ultrasound should be enough. Just in case you think you are not confident enough to handle it at your own place, probably that's when you can go for an MRI. But the typical features of adenomyosis are almost always going to be same. Posterior wall, this typical appearance which madam was just playing, okay? The posterior wall thickness grossly enlarged as compared to the anterior wall thickness, along with associated, transposition of the endometrial cavity or the endometrial lining, okay? And along with, of course, ovaries getting stuck to the pouch of Douglas, or, onto the posterior aspect with an absent sliding sign, along with some parts of the intestines, whichever part, has come and got attached. So that is something which we need to keep in mind, because otherwise adenomyosis is so typical, be it focal or globular, that it's going to be really difficult to miss it out.
When would you recommend MRI, Jay? When you're not confident about diagnosis or any other?
Maybe. But see, we are a referral unit, and now we have people who are so well trained in ultrasounds that we don't do MRIs, to be very honest with you. We are not doing it. But as I said, just in case somebody is not confident or reaching that stage, probably, see, I'll be very honest about it. I am not a very great ultrasonologist, though I have taught Vismay. He's a much better ultrasonologist than what I am. Okay. Even Toral is much better than me. That is because I personally don't do ultrasounds since quite some time now. Okay. They are the ones who are in that scan room 24 hours since the last 3 years. So they are much better, though they are trained by me. I'm proud to say they are so much better. But it is because now they are dedicated into it. Okay. So if you leave it to me, when I started off, I used to miss out on 80% lesions. I used to be a laughing stock. Okay, but then when I got myself trained into it, I used to pick up 90% of the lesions. And now when these boys and girls, they do the ultrasound, they end up picking almost everything, and which is very good. So it requires training. There is a learning curve associated with it. Members should understand that they have to negotiate the learning curve. If they negotiate the learning curve, they'll do very well.
Right. Just a comment here, Jay. I think obvious adenomyosis is easy to pick up on ultrasound, even by a novice. But it is more, it's the more subtle signs like these myometrial cysts or the junctional zone, which is a little irregular.
Altered.
Yes, altered. And these endometrial buds, which should be picked up by us as well.
Correct. Absolutely, they should be picked up. And but as the experience increases, people would end up picking up these things much better, is what I think.
Right. Now, coming to the case of this session, Jay, this patient is a 34-year-old with 10 years of secondary subfertility and recurrent pregnancy loss. She's been having dysmenorrhea since 7 years, and she's conceived spontaneously 4 times in the past.
Wow.
First time, yes, 4 times. And I'll show you her ultrasound image. And she was actually referred by one of our own colleagues who's online on the session today. And she had a first trimester miscarriage 7 years ago. Then she had 18 weeks miscarriage. Then at 30 weeks, she had a severe preeclampsia and an IUD. And then again, just in July 2023, she had again a first trimester miscarriage. Both causes of recurrent pregnancy losses, genetic, autoimmune, endocrine, male factor, uterine anomalies, endometrial causes, all these have been ruled out. She has a normal AMH and all were spontaneous conceptions, no IUI, maximum ovulation induction, and she would conceive.
Yeah.
Now this is a tricky case because this is what her ultrasound showed. This was a day 2 ultrasound. Again, severe posterior wall adenomyosis, and the uterine length is 10 centimeters, posterior wall thickness 6 centimeters, anterior wall thickness 1.4. So this is how the ultrasound looked, and this is what we want you to throw light on. This patient wants to conceive naturally.
Yeah. So I think considering all her past histories, see, one thing I would like to tell you, that apart from the 30 weeks intrauterine fetal demise which she experienced, okay, rest of the pregnancy, the poor outcomes which she had, the 18-week, the second trimester abortion, and the 2 previous first trimester abortions were definitely related to this particular huge adenomyoma on the posterior wall of the uterus. And it is very surprising that despite 4 pregnancies, the posterior wall adenomyoma is as bad. Okay. Because when something has reached a 30-week size, when the pregnancy has reached 30-31 weeks in size, okay, what normally would happen is there will be a lot of uterine remodeling which will occur when the uterus is undergoing resolution and coming back to normal. So despite all that, if the size is so big, okay, one of the things which people should advise for a 6 centimeter posterior wall adenomyoma is definitely to go in for an adenomyomectomy with a flap resection. That is the first thing. You also mentioned that the size of the uterus was 10 centimeters. Okay. This is good for academic purposes, but it looks slightly bigger than 10 centimeters to me. Okay. As far as the length is concerned, because you have really enlarged the field of vision to accommodate this uterus. Okay. So it looks to be much larger than that, to be honest with you, madam. All right. Definitely, the counseling points are going to be damn important, because when we do an adenomyomectomy, okay, in a situation like this, though the endometrium appears to be good, compressed along the anterior wall, what is going to happen is a small part of the endometrium might get compromised while doing the surgery. Okay. See, we are not going to remove 100% of the adenomyosis. That's a very important counseling point. We are going to debulk it optimally. Okay, suboptimal debulking is going to persist the pain. Okay, optimal debulking is what is important because it ensures a good outcome of the pregnancy. All right, can you scroll back to that ultrasound image and we will know something very important. See that? So people, if everybody watches that ultrasound which madam has played, see, there is one, we can pause here. See, there is one very, very important part in this ultrasound. One, it is measured on an E10. So please note, the ultrasound machine is a fantastic machine. And second, if you locate the posterior wall, no, you will see at the posterior fundal wall, okay, at the posterior fundal aspect, see, that is very, very hazy. That
Right.
boundary of the adenomyoma is very, very hazy. Now, this is something which is a classical appearance of something called as FAOM, which is focal adenomyosis of the outer myometrium. All right, that is a very classic appearance. See, second point you must notice in that is that the adenomyosis is extending right till the level of the cervix there. In this ultrasound, if you see, it is going right till there. Okay, so this no is going to require a huge debulking, and whenever you have something like this, it is important to note that some amount of serosa will get compromised. Okay, whenever this little amount of serosa gets compromised as a part of doing your surgery, okay, it may or may not be very easy for people to construct flaps. Okay, and because it may not be very easy for people to construct flaps, it is important to understand that your uterine reconstruction is done very, very beautifully, okay, in this type of a situation. So definitely this is one case, especially based on this ultrasound image, where I would say that it is going to be ideal if you get some expert to operate this adenomyosis. Otherwise, your suboptimal debulking will give you a recurrence in the next 3 months. Okay, and it will cause a severe lack of wound integrity. Okay, and whenever there is a lack of wound integrity, you are exposing this lady to a higher risk of rupture, okay, in the subsequent pregnancy. So just keep that small point in your mind. Okay, so we can go back to the next points of discussion, Aarti madam. Definitely one more very important thing in this situation is you must counsel the patient that there is a chance that the tubal factor might get compromised as a part of this surgery. See, you might be the best adenomyosis surgeon, but the way in which the endometrial cavity gets distorted, okay, during the time of removal of adenomyoma, there is a compromise, slight compromise of the tubal factor, which you have to explain to the patient, because even if they want to conceive naturally, if the tubes are gone, okay, then remember one thing, that type of thing will not be possible for the patient, right? As far as medical protocols are concerned, see, we all know any uterus less than 10 centimeters in size, you can give letrozole plus regestrone as long as it's a diffuse adenomyosis. See, please understand, friends, this is not a diffuse adenomyosis case. Diffuse adenomyosis is also going to cover a part of the anterior myometrium. Understanding here, the anterior myometrium is absolutely beautiful. So here, letrozole plus regestrone combination is not going to work. This is a patient in whom you should not be attempting that. This is a patient who should be going straight for surgery. Okay. One very important thing, okay, as a particular line has been written, pre-FET protocols will still apply, and what is yours? Okay, see, if the tubes are gone as a part of this particular thing, you know, what I would do in a situation like this is very simple. I would actually prepare an embryos first. In this situation, I would actually do the ovarian stimulation, okay, prepare the embryos and freeze the embryos for this patient. If the tube is compromised, okay, this is all provided the patient is affordable. Okay, if the tube is compromised in this particular situation, then the patient has an excellent healing time of around 2.5 to 3 to 4 months, which you have given on frozen embryos. Okay, friends, also note, when you have focal adenomyosis of outer myometrium, it is highly unlikely that the ovaries are not adherent. Okay, though as a part of this case discussion, two surprising things. Okay, one, the ovaries are not adherent and AMH is 3.5. I mean, that is amazing. Okay, because normally it would be 0.35 in a situation like this with such a huge adenomyosis. And in that situation, one important counseling point would be, even if we do everything correctly, you still run a risk of abortion because of your low AMH, which will give rise to a poor quality oocyte. Okay, so that would have been a point of counseling there. But otherwise, when you talk of pre-FET protocol, see, when we do an optimal debulking, so myself, Aarti madam and Shilpa madam and all these people, Padma Priya madam, we have this habit that quite a lot of times we get the ultrasound inside the operation theater. Okay. And as soon as the surgery is finished, I know Mamta madam loves doing ultrasounds, and Mamta madam would immediately put a probe inside before the patient is out of anesthesia and verify how much it is debulked. Okay. And that is something very, very important, right? It gives you an idea on table on how much is the debulking which has happened. The second idea you are going to get is when the patient gets back to you in that first menses. Guys, believe me, with such a huge adenomyoma, when your debulking is optimal, now we have had countless patients at all locations who have come back and told our primary consultants that, boss, thank you so much. I don't experience the type of pain which I was experiencing before. Okay, that is another sign of an optimal debulking. Then if you are planning the patient to be put on FET, you have an option to use a GnRH agonist, just in case some people like to use it. But I want to mention a practical point here. Don't start the GnRH agonist immediately. Okay, because what happens is you must allow the sutures to undergo hydrolysis. Okay, if you start GnRH agonist immediately, no, the uterine musculature will undergo some amount of apoptosis and it will shrink. Okay, it will make your sutures very loose. The sutures which you have done to approximate the cavity will become very loose. Okay, that will not cause a very good healing. So one take home point should be that after your surgery is done, and if you want to use a GnRH agonist, then you use the GnRH agonist after 1 month of surgery, where 80% of the sutures have undergone hydrolysis. Okay, so then there is no risk of causing a poor scar on that particular uterus. And I think that should be a very important take home point. Okay, for all the people who try to apply that in their practice, right? So I think, Aarti madam, I've covered the points, but if in case you want to ask me, I am more than happy to answer.
Right. Jay, you just mentioned that don't give GnRH agonist immediately after surgery because that compromises wound healing. That's a very good take-home message. So would you advise the same for letrozole and regestrone?
Letrozole and regestrone don't cause any apoptosis, madam. See, the thing is, both are anti-estrogen, anti-progesterones. So first they will go and act on the tissue which is remaining, okay, which has that particular abnormal receptor to fulfill. The problem with GnRH agonist is it will go and act on ovary, uterus, lung, bone. It will go and act everywhere. It doesn't really know it, right, madam? So that is the reason why there is no harm in giving GnRH agonist for embryo transfers after adenomyomectomy as well. But if possible, try and wait for a month, provided proper closure has occurred, fibrosis has set in, okay, and the wound has healed, then you give it, okay, then it will be really beneficial is what I think.
Right. Now, what if, during surgery, you feel the tube is not compromised? How long would you wait before again moving into IVF for such patients?
Around 3 months at least, madam. You must wait for 3 months.
Right. Now, the other day I saw a patient where an adenomyomectomy was done elsewhere and the patient came to us and I saw too large. Patient was quite comfortable with her dysmenorrhea, but she had too large hydrosalpinges.
Yeah.
Sound. So what do you do about this when you see it? You know that they're not communicating, so you just leave them alone and proceed with IVF.
No. But see, now there is a problem here. Okay, even if those hydrosalpinges are not communicating, they formed a hydrosalpinge because of adhesions, secondary adhesions, post surgery. One of the things to counsel the patient is to at least take it in writing from the patient that we will de-link or we will do salpingectomy. Okay, even if it is not communicating, because what typically happens is the micro communications, that small tubal to endometrial cavity fistulas and all these things which develop, we don't really know, madam. Okay, it is better that when you see a hydrosalpinge, you counsel the patient for a de-linking or salpingectomy. I prefer salpingectomy, to be very honest with you. Okay, because I cut absolutely flush to the fallopian tube, so there is no compromise in the mesosalpinges. All right, but I prefer salpingectomy. I will not recommend de-linking.
Okay, what is the difference you see in the outcome of de-linking?
No
because
difference.
Of our colleagues do
de-link. No difference. De-linking is easy. The problem is if you have not de-linked it correctly, okay, it will still stay patent. Okay, and that is something which you will see occasionally.
Okay, super. So moving on, Jay, that was terrific. All the points you gave us, very, very practical. Now, the same patient, if she had an adenomyoma like this.
Yeah, I think this is so important. See, this this laparoscopic picture which you see, okay,
Right.
this is typical, okay, typical of focal cystic adenomyosis of outer myometrium.
Right.
Okay, very, 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 very typical. Okay, the minute you cut this, there will be oozing of chocolate material from that. Please remember, this serosa has to be taken out.
Okay.
You can't leave this serosa inside. Okay, that serosa has to be taken out. Reconstruction in this is going to require an effort, and you need to be really, really sort of well oriented to the anatomy and skilled to do a good reconstruction for this particular lady. And one more thing, this is highly painful also. Okay, this is a highly painful condition. Highly painful. It is like the vacuums,
Right.
accessory cavitary uterine mass. It is like that. Highly painful. Oh God. I mean, very much painful. So you have to operate these people and they will bless you. Forget having children. They will bless you after the surgery. It's such a good outcome,
Super. Okay. And just a summary of the 3 previous sessions on adenomyosis, which we've had take home points from your end on the 3 types of patients we had discussed, Jay.
Yeah. So first thing I wanted to tell that summary Bellagio fountains which you had shown is absolutely fantastic in Las Vegas. If people who have not gone to that, it's something which they must visit. Okay. Sorry for the distraction, but it is too good. All right. Okay. But coming back to the final summaries, see, can I actually share screen? Aarti madam, let me see
please.
if I can share screen.
I'll do that.
I will 1 minute. Let me just see if I can just stay unmuted. I'll try to share my screen. Okay.
Okay.
Yeah. You can see, right?
Yes.
Okay. See, of course, I'll try to really simplify it. And for people who are watching this masterclass alone, it will not help. You should go through the entire series. Okay. So when we are looking at adenomyosis, your treatment plan should be very simple. All right. Is it focal or is it diffuse? Okay. When it is focal, is it less than 3 centimeters? Is it more than 3 centimeters? When it is diffuse, you have 8 weeks to 10 week size uterus. You have something which is more than 10 weeks in size. These are the 2 common things which you have. Of course, I'll add, one third entity which is very common these days. And that is focal adenomyosis of outer myometrium. Okay. Now, this particular guy is almost always in more than 60% to 80% of the cases associated with deep endometriosis. Okay. And this you have to operate. There is no question. Okay. Focal adenomyosis more than 3 centimeters, which is present. 98% of them will present with pain and you have to operate. Okay. Less than 3 centimeters is dicey. You can give all your miri masala. You can give painkillers. You can give combination of letrozole plus registrone. You can give combination of Dynogest. Okay. You can put Mirena. Okay. You can use GnRH agonist. Everything will work here. Okay. For uterine size less than 10 centimeter with diffuse adenomyosis. Okay. 8 to 10 means less than 10 centimeters. Let me just put it that way. One of the treatment of choice for everybody is to use letrozole 2.5 mg in the night, registerone 10 mg in the morning, and you continue this for max of 3 months. Okay. You will experience approximately 10% to 15% volume reduction. Okay. And it will take care of the pain very nicely. Of course, you can use letrozole plus Mirena also, because Mirena is just like registrone. Okay. This is a combination which will work way better than a GnRH agonist. This is, in my practical experience, the preferred combination. Second only is, Dynogest alone, which I really don't like. Third is GnRH agonist alone, which again I don't really like. GnRH agonist can be used for your FET protocols. Just like how you can use letrozole plus registrone for FET protocols as well. Okay. If there is diffuse adenomyosis more than 10 weeks, the take home point is no matter almost what you do, okay, ultimately these patients will end up with surgery. Please remember that. Okay. Very, very important that patients with adenomyosis also almost always will present to you with low AMH and ovarian endometriosis in the form of chocolate cyst. Just in case you are doing this particular exercise for a girl who is unmarried, kindly give them an option of oocyte banking. Very, very important in my humble opinion as a practicing gynecologist. And this is something which we should very strongly consider. Unfortunately, many people don't really give these options. And you will find the AMH is 0.5, 0.3. And most of these girls would end up with donation programs. Okay. Otherwise, in adenomyosis, what is very, very important for everybody to remember, irrespective of it being focal diffuse or focal adenomyosis of the outer myometrium, okay, it is important that people remember this particular line, that when you have an endometrium which is drawn here, okay, if the endomyometrial junction is irregular, okay, no matter what surgery you are attempting for adenomyosis, your outcomes of reproduction are severely compromised. Okay. They are severely compromised. If you, on the contrary, if you have a beautiful triple line, okay, you have a beautiful triple line like this, okay, nice triple line which is formed, and you have this entire region as adenomyosis, even if you operate and your operation is good, okay, you will have good reproductive outcomes. So when I say good reproductive outcomes, in my hospital at least, the success rate of IVF varies between 35 to 40% as live births. I know I'm one of the least successful IVF consultants this country has ever seen. I apologize for being born in India. Okay. But if you have adenomyosis on top of it, your success rates would rarely exceed 25%. Okay. With adenomyosis, there is a 10% drop of success rate, irrespective of the age and irrespective of the endometrial lining. If you have a distorted endometrium, then this success rate would actually go down to less than 10%. And that, in my opinion, is a very, very important counseling point to our patients whenever we are trying to talk to them about reproductive outcomes as far as adenomyosis is concerned, because that is something which is very, very important. All right. And finally, I want to tell one thing to everyone. When you look at adenomyosis, there is this huge confusion because, see, there are people who don't want to offer a surgery to the patient because they are not very highly trained in that surgery. There are people who don't want, there are people who want to offer a surgery but don't want to do a complete job. Okay, they want to do a suboptimal job. I think with so much amount of literature and data available across the country, and we have such good endoscopic surgeons in our own country, okay, I guess the time is right for every individual fertility consultant to at least observe and get into the training of at least knowing how much optimal is optimal. So that even if you are inviting a traveling surgeon from outside to your hospital who is doing dedicated endoscopy work, you and your associate can have a joint discussion with the patient prior to the surgery, and you can achieve optimal reduction of adenomyosis in almost all the patients. Okay. And I think that probably are the important take-home points which I thought everybody must know before we conclude.
Superb, Jay. A very, very outstanding flow chart you showed us. So simplified and very clear in its message of when to use medical management and when to go for surgery. Someone called it a master stroke, and I agree with that statement one of our colleagues made.
Is Dr. Megashri Deshmukh.
Yes, yes. And I think we'll conclude today's session. You gave us brilliant points, Jay. So much to chew on. I think we'll have to see this session at least a couple of more times and make notes as well.
Sure. Yeah. If there are one or two more questions, I'll be happy to answer.
Okay.
Why do you think the AMH is reduced in majority of cases of adenomyosis? Because we see it.
Yeah. See, the reason why AMH goes down in adenomyosis is because of a huge amount of cytotoxic milieu which is generated by endometriosis and adenomyosis. See, the reason why we always scratch everybody's head and we tell people that you do peritonectomy when you are doing oophorectomy or ovarian cystectomy in endometriosis, because now everybody loves molecular level and cytogenetics and all these things, no? This cytogenetics actually goes and affects the ovarian cortex. Okay. And this affecting of the ovarian cortex actually causes a lot of premature destruction of these follicles. Okay. Because of a very unhealthy milieu. And as a result of this, you will typically see, even if they have been never been operated before, no, they will have a reduced AMH. Okay. Which is why our senior colleagues have called this surgery to be fertility enhancing surgery. So that you do a complete job and you change the pelvic milieu inside. And once you change the pelvic milieu, the oocytes would start responding much better, right?
Right.
Yeah. What about role of mesh repair? Like you said that serosa has to be removed in cases of cystic adenomyosis. So
my first patient delivered today, actually, Shilpa madam, in whom I had done mesh repair in pregnancy. Actually, Hafiz sir has also done it, to be very honest with you. Hafiz sir has also done it, and Hafiz sir has had 1 delivery out of it. I have done 6 so far. I think Hafiz sir would also have done, okay? I know only of my data, and my first patient delivered today in Abu Dhabi, okay? For a mesh repair post adenomyomectomy for a thinned out myometrium.
No, but how do you check it? Like in NT scan, they check the myometrial, the integrity.
So most of the times, no, madam, they will come to know about it as much early as 6 to 8 weeks. Okay, because what happens is once the cavity starts expanding, there is going to be a part of the serosa which is going to have the dimple inside. Understanding, because of the fibrosis. And the dimple, no, you will have loss of serosa there. You will have loss of myometrium there. So you will have an abnormally thinned out myometrium very early in pregnancy as well. Okay, obviously it becomes very, very thin as the pregnancy expands. And as a result of it, the best time to put the mesh is, before 14, 15 weeks, if in case it is required. You can put it later also. But that is the best time to put that double mesh. Okay. And it's a very rewarding surgery from what I have seen, madam.
Okay. Okay. Yeah. Yeah. I think, from my side, that's all. So,
Yeah.
Aarti,
Yeah.
you can take.
Yeah, and few of our colleagues have asked about management in adenomyosis where family is completed. I ask you all to see previous second blast series. It's a very comprehensive and detailed explanation given. Letrozole registrone combination was asked, and this again is explained in our first blast series. Letrozole bedtime, alternate day, and registrone in the morning. I think we are done. Yeah, I think we are done. And that was a fantastic session, Jay. And we know that you have to catch a flight to Sri Lanka tomorrow. So I think we'll end today's session. It was absolutely brilliant.
Thank you, Aarti, madam.
Thank you. Thank you to all